So good evening or afternoon, I guess, depending where you are. I'm currently in New York City. My name is Kira Reinhold. There was a slight mistake on the promo for the session. But I'm a third year slash rising fourth year. I'm finishing up my third year right now at New York Medical College, which is in Valhalla in Westchester in New York. Hence why I live in New York City. And I'm excited to be giving you guys a talk today on sexually transmitted infections. There's a lot to talk about, obviously, way more than an hour. There's so many different STIs. There's a lot to talk about in terms of treatment and diagnosis. We're just going to get our feet wet today and talk about a couple of them and, getting a history and some quick things about diagnosis and treatment. A little bit about me. Oops. So I went to Yeshiva University for undergrad. I actually majored in English, um, which I'm happy to talk about with people if they have questions. I think it was a really great decision, and I really loved my English major in the English department at my school. Like I said, I'm at New York Medical College, finishing up my third year, taking step two in a few weeks. I joined Motivate MD more than 2 years ago now in April 2022. I actually got involved because I used their services when I was applying myself. And I serve in many roles here. I'm an editor and an advisor, and I also do interview coaching. Here's a picture of me on my trip to Thailand a few months ago, showing you guys that it's possible to have fun and have a life and go on vacation while you're in medical school, so don't worry. So the session outline, just like all the other sessions, we're going to start with the case. We're going to go into the physical exam, the differential, talk about an assessment and plan, and then go into a little lesson on the pathology of the disease that we're talking about. Again, please actively participate if you want to unmute yourself and ask a question or answer a question if I ask. Try to monitor the chat. If something pops up, I think I'll see it. And if not, I'll monitor it periodically to answer your questions, and then I'll answer any questions at the end as well. Also, remember to fill out the SOAP note throughout the presentation and then finish the quiz when we're done. All right, a quick poll to start things off. I didn't actually do the poll function, but just type in the chat what you think the answer is. What is currently the most common sexually transmitted infection in the US? Is it herpes, gonorrhea, chlamydia, syphilis, or HIV? Okay, we're getting a lot for C. So that's chlamydia, some herpes, some people saying gonorrhea. I would say mostly between A and C. Okay, cool. So we'll find out the answer to this by the end of the presentation, but I'll just spoil it for you because it is very important and it's really important to know both as a pre-med and a medical student and eventually once you're practicing. The most common STI right now is chlamydia. Chlamydia is actually, it was on the rise in the last few years. Now it's going down slightly, but it's currently the most common STI. I've actually seen, when I was in my family medicine rotation, we saw a bunch of cases. All right, so just remember to get the SOAP note in front of you so you can take notes and fill out everything for the session. All right, so let's start off with our case. So a 19-year-old female comes to the family medicine office for a work physical exam. She states that she has never been diagnosed with any medical conditions and takes no medications. However, during review of systems, she endorses feeling some burning when she urinates and whitish yellow vaginal discharge. You find out that she has been feeling the burning for about 5 days. It is mildly uncomfortable, and she has been drinking cranberry juice because she suspects she has a UTI. She states that she first noticed the unusual discharge yesterday. Her last menstrual period began 10 days ago. Her periods are regular every 30 days, last 4 to 5 days. In terms of her social history, she's a student at the local college. She lives in an apartment with her 2 roommates. She's never smoked or used any tobacco or e-cigarettes. She has about 1 drink a week, and she denies any recreational drug use. All right, so in the chat, what stands out to you guys here? Anything in particular? There's not really much here. It's pretty short, but there's a couple things that I just wanted you guys to pick up on. Um, yeah, so it's essentially the burning sensation and the vaginal discharge. Those are really the only 2 complaints that she has. And if you notice, they weren't even that major. She didn't even bring them up until you prompted her and asked her about different symptoms she might have been having. So she was feeling fine when she came in. It's only that when you prompted her, she told you that she was feeling these minor symptoms. Yep, so I've just highlighted the most important things for our case on the slide. All right, so she's mentioned these two symptoms. Now, a big thing that you want to do when you're getting a history is to find out associated symptoms. So think about, you can jump ahead and think about what we think she might have, and then think about what other symptoms might be associated with that we want to ask her about to see if she's having. So I'll give an example, and then you guys can jump into the chat. So she said she's having burning with urination. So I'm thinking, okay, maybe she has a UTI. I want to ask her if she has increased urinary frequency, if she's peeing more often. See what you guys said. I don't know. Apathy is okay. Like if she's feeling any lymph nodes. I don't think I put that one down, but yeah, because that could be sign of infection. So if she's having an infection, we want to think about that. Anyone else have any other symptoms they might want to ask her about? Think about she's having the burning. Yeah, fever. So she could be having an infection. So let's think about fever, obviously. Rash. Yeah, rash is good too. Abdominal pain. Yeah, these are all good. The scale of how bad burning is. Yeah. Lymph nodes. Okay, great. So I'll put what some of the ones that I put on. So increased urinary frequency. Looks like I said she's having the burning with urination. Abdominal pain, someone said. So maybe I'm starting to think about you could have some sort of abdominal pain, like suprapubic pain from a UTI, but if you have STI and she says she's having the discharge, you can also have some abdominal pain. Does the discharge have an unusual smell? So we'll get to this later, but some STIs actually, you're not going to diagnose it based on the smell, but questions that you'll see when studying for a STEP or the boards, or even in real life, you might want to ask them if the discharge has an unusual smell. Um, any skin lesions or changes on her vulva/vagina, because for things like herpes, even syphilis, those are going to be big things you want to look out for. Pain with sex or insertion, so we'll talk about this later, but if you have inflammation of your cervix or inflammation of the walls of the vagina, inserting anything can be painful, so we might want to ask about that as well. Any vulvar vaginal itching, joint pain, so we'll get to this later, but actually there's some kinds of gonorrhea infections can cause joint pain, so that was a long shot, but if you're doing a thorough history, that's something you might want to ask about. And like you guys said, any fevers or chills. So this isn't I didn't put the lymph nodes on, that one's good too. This is just some other associated symptoms. Obviously, I don't have everything, but if you're, trying to do a thorough history physical, you have 10 minutes with a patient, these might be a couple good things to ask. All right, so she answers our questions. She's not having any increased urinary frequency, no joint pain, smell, itching, abdominal pain, lesions. She says that she's having mild pain with sex for insertion of a tampon, let's say. So that might lead us to think, okay, there's some sort of inflammatory process going on, either, somewhere in the vulva or the vagina or the cervix. All right, so there's a pretty obvious part of the history that we're missing here. So before we move on, what's kind of the most important thing we want to talk to the patient about now? Yeah, sexually active. Yeah, sexual conducts, condom use, sexually active. Yeah. So this is the big part for our taking the history with this patient. We want to get a good sexual history. So hopefully your medical school that you attend one day, or if you are in medical school, they give you a really great when you're in your first 2 years, at least my school, they gave us like a great few sessions about how to ask for a sexual history. Um, Obviously, it can be very sensitive for patients. They might have just met you 2 minutes ago. They don't know you, and now you're asking them to tell you these details about your personal life, especially if it's a younger person, like a teenager, or in our case, she's 19 or 22. It can be uncomfortable. So, um, we're not going to go. I could talk for an hour just about taking sexual history. We're not going to do that today. But just some things to think about when you take a sexual history is just making sure the patient feels comfortable. Always starting off, with giving them a little intro. Okay, I'm going to ask you some questions about your sexual history now, things like that. So let's jump right into it. All right, so I put all these questions on here. These are questions you might want to ask when you're taking a thorough sexual history. There's a lot more questions you can ask, and I've linked the CDC guide to taking a sexual history on the next slide. That's where I got these questions, and that's a great resource if you want to learn more about the sexual history. But just for our case, I think these are some relevant ones that I've gathered that I would want to ask the patient. So obviously, first I'm going to start off and say, may I ask you some questions about your sexual history? That's a good way to, get their consent to keep going and just let them know that you're going to ask these questions now. And you want to say, okay, are you sexually active? So the way that I might phrase this would be, are you currently having sex of any kind? And it's really important to distinguish or just sort of elaborate and talk about the types of sex that they might be having, because someone who's only having oral sex might not, because they're not having penetrative sex, they might not think that they're having sex or being sexually active. So you want to kind of clarify that when you do your sexual history. And then asking them what kind of sexual contact they have. Certain types of sexual contact put them at greater risk for certain STIs, so it's important to get a sense of what kind of sexual contact you're having. In recent months, how many sex partners have you had? What is or are the genders of your sex partners? And this is important. Are you and your partner trying to get pregnant? Don't assume that everyone is not trying to get pregnant. Some people are. So, when you talk to them about contraception, they might specifically not be using contraception. But always just ask to sort of get on the same page as them. Do you and your partners use any sort of protection against STIs in or pregnancy? And have you ever been tested for STIs? So this is a lot, but I think for our case, it'll get us like a good sense of this patient's sexual history. And I don't know if the link will work here, but you can just Google it, like CDC Guide to Taking the Sexual History. I found that this is really helpful. It goes into depth and gives you different categories. I think there's like the 5 Ps that people will sort of classify the sexual history into, but it's really helpful. So definitely take a look at that if you're interested. All right, so we get her answers. So she's very happy to talk to you about her sexual history. She says that she is having sex. She has vaginal and oral sex. In the last 3 months, in the recent months, she's had 3 sex partners, male and female. She's not trying to get pregnant. She sometimes uses condoms and she's never been tested for STIs. So I just want to talk about why. Again, I'm asking all these questions. So obviously, it's important to ask if she's sexually active, because um, that'll clue us into, what kind of diagnosis we're looking for, because there are certain conditions that can present like STIs, like let's say a yeast infection that would present with like itching or discharge, but those actually are not sexually transmitted. So you could be not sexually active and get a yeast infection. So just kind of having this information will help us later on with that diagnosis. And then in terms of the number and the genders of the genders of the sex partners, again, because like I said, certain types of sexual contact can predispose a patient to certain STIs. You want to kind of get a sense of who they're having sex with. And of course, the most important part here is if they're using any sort of protection. So anytime someone doesn't use a condom, they're putting, there's a risk of getting an STI. And again, we'll talk about this later, but always counsel patients that even if they are in contraception, like if they have an IUD, they're on the birth control pill, that doesn't protect against STIs. And we want to ask her if she's been tested, because obviously, the plan today is going to include testing for STIs. Okay, so before we like dive into the STIs and talking about the different kinds, I want to just give a quick anatomy lesson. This is really important. I don't know if I knew this before med school, because when we're talking about, the ways that STIs present, we really want to get a sense of the different parts of the female genital system, and sort of so we know what we're talking about. So there's the vulva. This is the vulva. The vulva includes all of these parts: the mons pubis, the labia majora and minora, the clitoris, the urethral opening, and the vaginal opening. So I don't know if you can see like what I guess I can draw. So this is all the vulva, not the anus. But everything here from the pubic mound all the way up to the vaginal opening. But the vagina itself is just the muscular canal connecting the vulva and cervix. So I think I get to this on the next slide. So this is the vagina. The vagina is just, from the opening to the cervix, it's the canal. So when we talk about someone having a lesion on their vagina, that wouldn't really make sense. We're just talking about, you would probably be talking about the vulva, because we go back. The lesion would probably be somewhere in their vulva. So we're going to talk about these parts later when we talk about which specific organs that STIs affect. So I just want to make sure we have a good grasp on the anatomy and what we're talking about when I say vulva, as opposed to vagina. Okay, we just clear this. Okay. Um, so the cervix. Let me draw again. So we have our vulva over here. The vaginal opening is in the vulva, and the vagina is going to take us up to the cervix. So the cervix is sort of like the end of the uterus. Here we have the uterus. And the cervix is the opening of the uterus, and it connects, it's this like little area here that connects the vagina to the uterus. So if you have any experience in OBGYN, when they say a patient's dilated, it's that their cervix is dilated because the baby is coming out from the cervix into the vagina. Clear this up again. And another important term, which I hadn't even heard of till I got to med school, is adnexa. So you'll hear people say the word like adnexal mass or adnexal tenderness. That just refers to sort of anything in this area. They're not really in this drawing, but there's all these ligaments that attach the ovaries to to the uterus and the fallopian tubes. So when someone refers to the adnexa, they're generally just talking about the entire this entire region, and we'll talk about that later as well. Okay, so we kind of got this. This is just a brief review of her sexual history. Like I said, she's has 3 partners in the last 6 months. She's been sexually active for 6 months. She's currently having oral and vaginal sex with a male partner, and she occasionally uses condoms, states that sometimes she doesn't because they don't have any on hand, and she's never been tested for STIs. All right, so let's get into the physical exam. So let's look at her vitals. Her blood pressure is 117/83. Heart rate is 75 beats per minute. She's breathing at a rate of 15, and her temperature is 97.8. Anyone worried about anything here? No. Yeah, I wouldn't be worried either. Everything's normal. She doesn't have a fever. Um, yeah, her vitals are totally normal, which is, I think, what we would expect. All right, so we're gonna get into the physical exam. But any specific part of the body that you would like to examine? Obviously, we're gonna do a pelvic exam, so don't worry about that. But anywhere else? Anything else anyone specifically wants to look at or curious about? Mouth, okay. The pharynx, the mouth, oral. Yeah, so very good. Um, so obviously there are STIs that can have manifestations in the oral cavity, like herpes. Um, Not really sexually transmitted disease, but Epstein-Barr virus or the mononucleosis virus can be transmitted by like contact with saliva. So that maybe also we want to look at her pharynx or her lymph nodes in her neck just to see what's going on there. All right. So let's go to the physical exam. So her head is atraumatic normocephalic. Her pupils are equal. I always forget what this stands for. But essentially, her pupils are equal and reactive to light. Her mouth, so her mucous membranes are moist, meaning she's not dehydrated. She has no mucosal lesions, so we're not worried about oral herpes. We didn't see anything in her mouth. Um, in her pharynx, the mucosa is not inflamed. She doesn't have any tonsillar hypertrophy or exudate. No cervical lymphadenopathy. Her heart rate is she has a regular heart rate and rhythm. No murmurs. She's breathing comfortably on room air. Lungs are clear. Her abdomen is soft, non-tender to palpation. No organomegaly or masses. Anyone know what CVA tenderness is and why you might have wanted to look for it in this case? I didn't know what this was till I started medical school, so no worries if you don't. Um, CVA is costovertebral angle. That's essentially in your back where your kidneys are. So when a patient has a kidney infection, like something called pyelonephritis, or you always want to check, it's sort of an exam maneuver. Can't really show you, but you have the patient's back and you sort of just like tap with your fist, like on their 2 sides where their kidney would be. because if they have a kidney infection, they might feel pain when you do that maneuver. So if you suspect UTI or a kidney infection, that's something you might want to do. But she's fine in this case. Um, oh, CVA, cerebrovascular accident. Yeah, so the thing about multiple acronyms in med school, it's about context. So, um, like if you're looking at a physical exam in someone's note, I guess, and you see back CVA tenderness, I guess your brain has to kind of think, okay, costovertebral angle versus let's say you're in the neuro clinic and you're reading a patient's history and you see history of CVA, then it would make more sense to be like, okay, history of cerebrovascular accident versus history of costovertebral angle. But yeah, in medicine, there's so many acronyms and they're all the same. A lot of them are the same, but it's just about context and eventually you get used to it. And always, always, always ask. It's always okay if you're reading a note or you don't know what an acronym is to ask. It's not going to make you look dumb or silly or anything. It's totally fine. All right, so I would say pretty confidently that her physical exam so far is normal. Nothing here that, is pointing me in any sort of direction. Um, a quick pearl that I learned throughout my third year, and I want to pass off to you guys, and I actually didn't include it in the physical exam. I would say it's more comes in handy when you're in the ER. But the most important thing in the physical exam is the patient sick. So we come in, we do the physical exam, we're like, okay, let's look at the head, let's look at let's look at the heart, let's look at the skin. But the first thing you want to do when you go into that room, especially in the ER, is like, okay, what does this patient look like? And often you'll see they'll have like a constitutional part of the physical exam where it might say like patient is sleeping comfortably, patient is in distress, patient is like appears uncomfortable. So I should have included that. I would say something like patient is a well-appearing female, appears stated age, acute distress. It's not as important, let's say, I mean, it always is important, but it's not as important, let's say, like an outpatient setting. Um, but always, 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 especially with kids, people will often say like it's a sick kid or not a sick kid. And with kids, it's really easy to tell, especially with little kids. But I always just see like, okay, is the patient sick? Are they in acute distress? Because that's obviously you're still looking to do your full physical exam. It's kind of a good way to see what's going on. Yeah, general impression or appearance. Exactly. All right, so nothing crazy here. I would say everything here's gone well. So let's move on. All right, pelvic exam. So with the chaperone in the room, obviously we do a pelvic exam. We get her permission first. Um, on the vulva, there's no lesions, rashes, or changes of their skin in the skin or mucosa, so we don't see any, like I guess, I can't think of the word right now, but no like warts or the word is blanking on me, but like something that you might see like small lesion and um an STI. But yeah, so there's no lesions, rashes, something like that. So the bimanual exam. So quick note on the pelvic exam. There's a couple different parts. The first thing you're gonna do, and obviously, I hope this goes without saying, but you never do a pelvic exam without like permission of the patient and the permission of your supervisor. Um, so the first thing you're gonna do is you're just gonna inspect. You want to inspect the vulva, the skin around the vulva, just to look for any rashes or lesions or changes. Um, you might want to also look at hair distribution if that's something that, if that's something that might help you with your differential diagnosis. Then the next part is the bimanual exam and speculum exam. People will do it in different orders, but essentially the bimanual exam is you're going to insert your fingers into the vagina, and then with your other hand, you're going to be feeling the patient's abdomen slash pelvis. When you have the correct technique, you should be able to sometimes feel the uterus as well as the ovaries. And adnexal tenderness means that you do the bimanual exam, and as you're feeling sort of where the ovaries are and the uterus, the patient does, say that they feel pain. And then the speculum exam. So I don't have a picture of a speculum, but the speculum is essentially a small device that's inserted into the vagina so that the provider can get a good look at the cervix. So here, this picture, we're looking through the speculum into the cervix. I should have put a normal picture of a cervix in retrospect so that we can see what a normal cervix would look like. But on the exam of our patient, we see that it's erythematous, which means it's red, and there's moderate purulent discharge. Purulent means like white or pussy. So that's what we see here. So I would say this is like probably the biggest finding that we have on physical exam for this patient. Okay, so let's just give an overview before we move on. This is something that you'll be asked to do as a med student, essentially sort of to present the case very briefly. So we have a 19-year-old female with no significant past medical history who presents with 5 days of mild dysuria on 1 day of purulent vaginal discharge. Patient endorses sexual activity without regular condom use. On exam, there is mild adnexal tenderness, and the cervix is erythematous with purulent discharge. So just a quick overview of like who the patient is, what their history is, why they're here, what their symptoms are, and what the exam findings are. Okay, so I mean, you guys have already seen it because I skipped too quickly. But let's just make a quick differential. So, what do you guys think is going on? Be like as specific or as big as you want. Anyone? Okay, more STI, STD. Yeah, we can't rule out. I would say we can kind of put STI at the top, but I want to keep UTI in there because it's something that we can easily treat and it's something that can happen with an STI. So I would say STI is probably going to be at the top for me, and UTI is still going to be in there. And then I added a couple more things on. But yeah, I mean, obviously, you know from the title of the presentation that it's an STI. But let's go into the differential diagnosis. Okay. So I got a little more specific here. And you know, we haven't even talked about the different kinds of STIs yet, so I don't expect you to, you know, have decided which one it is and put it at the top. Yeah, pelvic inflammatory pelvic disease. Good. Um, so the thing with differential diagnoses, and everyone, every attending and every resident, every doctor has their different approach to it. But you always want to think about, okay, what's the most common? What's the most likely? What's going to kill the patient? Like, what do we make sure we don't want to miss? Um, and like maybe something like rare that it's probably not, but we want to rule it out. So I've put a couple on here. So gonorrhea and chlamydia, I would say those are probably most likely. Um, HPV, cervical cancer, those are more rare, but those are things that you wouldn't want to miss. Pelvic inflammatory disease, which someone mentioned, also something you don't want to miss. We'll talk about what it is. But yeah, exactly. Chlamydia would be more frequent, but pelvic inflammatory disease is more dangerous. So pelvic inflammatory disease can actually be consequence of gonorrhea or chlamydia or some other sort of sexually transmitted infection. But again, I want to keep it on there because it can be pretty severe and it can have some pretty serious consequences. Someone asked about hernias or prolapses. So I'm assuming you mean like a cervical or like a uterine prolapse. It's something I wouldn't be worried about here because the patient's so young, and those are pretty obvious on exam. I've seen patients in the OBGYN, on my OBGYN rotation, and you kind of do the physical exam. You can't even really do a pelvic exam or a bimanual exam because the cervix is basically at the vaginal opening. For those of you who don't know, prolapse is essentially when an organ sort of loses its like or the I guess the ligaments and the I guess the structural integrity of the organ is compromised, and so it sort of goes where it's not supposed to be. So, for example, with the uterus, it can sort of like get really weak and then prolapse like into the vagina. But like I said, I'm not worried about that here because she would feel a mass when she would, you know, like feel around down there by herself. And she doesn't really fit the presentation for that, and like we would have seen it on a physical exam. The last thing is irritant dermatitis. So that's essentially when the skin just gets inflamed because of a product this patient might be using or like an underwear material. So we can keep that on the differential, but I think you wouldn't really see a purulent discharge or like um, white discharge with that. So that's why it's lower down on the list. But that's also like a really common explanation for why someone might be feeling like discomfort. Dermatitis. Um, Yeah, so I mean, dermatitis doesn't necessarily mean that it's like on the skin. It could be like irritating the vaginal mucosa as well. All right, so like I said, we know it's going to be an STI because of the title, but let's keep going and talk about what we want to do for this patient. So I think it was supposed to kind of come in, but what I want to do for this patient is I want to get a urinalysis and a urine culture, and I want to get STI testing. So like I said, the two main things we're thinking about here are UTI and STI. Um, a quick note, it's really important to get patients' consent um, when you do STI testing. You want to not only say, okay, like we're going to test you for these diseases, you want to say, okay, and if they're positive, here's what we're going to do, and here's how we're going to treat them. There's unfortunately a lot of stigma around STIs, and patients have a lot of preconceived notions, and they might have misinformation. So some patients, might need a little bit more counseling in terms of, getting them to agree to STI testing. Sometimes they don't agree, and like, you counsel them on the risks, and it's okay. But essentially, you want to make sure that they consent. It's really important to get their consent before you do STI testing. Um, in the urinalysis, we just want to rule out a UTI so we can easily treat it with an antibiotic if she does have a UTI. Swab cultures and urine cultures, yes, we'll talk about how we get the STI testing. But for now, let's say we're gonna take a urine sample and then we're gonna do the STI testing through swab. So I guess I would have done it already. And to be honest, like in a real situation, you would get the cervical swab. So how you actually test for the STI is, um, in this case, you're gonna take like a swab and swab the cervix and then send it off to the lab. So we would have already done it when we're doing the speculum exam. But for our purposes, let's say we haven't ordered it yet, so we're going to order the urinalysis and the STI testing. So her urine results, I don't expect you guys to be able to interpret these. I didn't learn that until I was in med school, so we'll go through it together. So color is light yellow. Um, the pH is normal. Specific gravity is normal. Um, she's positive for nitrates, negative for leukocyte esterase, has a couple of white blood cells, not really any red blood cells, and no bacteria. So essentially, the way to analyze this is that nitrates and leukocyte esterase are usually positive in the case of an infection. But let me just clarify that. Not necessarily in like a urinary tract infection. It could be an STI and the bacteria are, lining the urethra. So it's not necessarily that it's a primary infection of the urinary system. But those nitrates and leukocyte esterates are like enzymes that bacteria produce that make their way into the urine if a patient has an infection. So when you see positive nitrates and or leukocyte esterase, even if the patient has no bacteria, you want to still sort of think about, okay, maybe there's some sort of infection going on here. And then the same with white blood cells. You see white blood cells, a lot of things could be going on, but in our case, I would say it's probably related to the infection. So I would say the conclusion from your analysis is that she doesn't have any actual bacteria in the urine. Um, and but there's bacteria making their way into the urine from somewhere. We're not sure where. Okay, so then here's the important part. So her STI testing comes back. So here's what we tested for. We tested for gonorrhea, chlamydia, syphilis, which is the VDRL test, HIV, and trichomonas. So gonorrhea is negative, VDRL is negative, so she doesn't have syphilis, she doesn't have gonorrhea, she doesn't have HIV, she doesn't have trichomoniasis, but she has chlamydia. Okay, so that's, I guess, our diagnosis. We can confident, confidently diagnose this patient with chlamydia. Someone asked about having a UTI without bacteria. So viruses don't really cause UTIs, nor do fungi, but you can have something called like a sterile pyuria, or especially in pregnant women, you can have like bacteria, like a sort of signs of infection in the bacteria with a negative culture. So you can still have UTI without bacteria in the urine. So that's why it's important to do a urine culture as well. So we don't have the results for that yet because that takes a few days. So we can't really rule out a UTI yet. But for now, we can kind of say, okay, well, it's possible that the chlamydia, since we'll talk about this in a couple slides, but chlamydia can really infect any part of the genital slash urogenital system. So, I would say in this case, what's probably happening is that the chlamydia has caused urethritis or inflammation of the urethra, which is what's causing the burning when she pees. Um, and as well as the discharge probably wouldn't be caused by the urethritis, that would be caused by the cervicitis. And as you recall, when we looked at her cervix, it was pretty inflamed, and there was purulent discharge. So, I would say that she has cervicitis and urethritis, secondary to chlamydia. So our assessment, so a patient is a 19-year-old female with no significant past medical history, presents with 5 days of mild dysuria, 1 day of purulent vaginal discharge. We said this already, she interrupts sexual activity, blah, blah, blah. On exam, there's mild adnexal tenderness, and the cervix is erythematous with purulent discharge. NAAT testing was positive for chlamydia. STI testing revealed no other positive results. Patient likely has urethritis, cervicitis, secondary to chlamydia infection. So it's kind of what I said before. So a quick note on assessment and plan. So something you'll see a lot in the hospital is X secondary to Y. So when a patient comes in with, let's say, a cough because of asthma, or I'll give you a better example. Like if someone comes in with like cough secondary to flu, obviously you get a positive flu test, you obviously want to include that in your assessment. We also kind of want to explain why the patient's having that. So that's when secondary to would come in. So it's like patient has this, so urethritis and cervicitis, secondary to, meaning caused by chlamydia infection. So it's sort of like the microdiagnosis, secondary to like the macrodiagnosis. So like a patient might have infertility, which is like secondary to caused by something else. So that I think will help you to write sort of a more thorough assessment and plan when you're able to sort of separate like what's actually going on and why it's going on. All right, so what's the plan here? So we have a patient with chlamydia. What do we actually want to do now? Yeah, exactly. Pulmonary edema. So like excess fluid in the lungs secondary to congestive heart failure. Yeah, so what do we actually want to do now? We have a patient, she has chlamydia. What are we going to do? We're obviously not just going to send her on her way. We're going to do something for her. Yeah, antibiotics. And one more thing I would want to do for her is counseling and education. And we'll talk about that. Right. So I put on my plan antibiotics, doxycycline, which we'll talk about. STI prevention counseling. So, talking about safe sex practices, things like that. And partner prevention counseling. We'll talk about that as well. But essentially, she got this infection from somewhere. We want to make sure that there aren't other people, like if anyone else has the infection, that they're getting treated as well. And there are actually a lot of different ways that we can do that. We'll talk about that later. And I wanted to come back into clinic in 3 weeks to make sure that the infection is cleared and just to follow up. All right, so what time is it? Okay, so let's talk about STIs. So like I said, there's so many of them. Today we're only really going to be talking about gonorrhea and chlamydia, just because they're very similar. But there's a lot of different STIs that can be caused by all sorts of things. So the definition is infectious disease of bacterial, viral, fungal, parasitic origin, transmitted through sexual contact. Quick clarification, I feel like a lot of you guys probably have heard them called STDs. The I guess the thing in medicine right now is it's preferable to call them STIs just because the word disease sort of has negative associations with it. So the proper terminology now is sexually transmitted infection, or STI. So here's a couple, and I highlighted the ones that we're going to be talking about today, but here's some really common ones. And STIs are caused by all different kinds of things. Like I said, bacteria, viruses, parasites. Gonorrhea, chlamydia, and syphilis are all caused by bacteria. Herpes, HPV, and HIV are all caused by viruses. And there's a lot more on this list. There's a lot, there's other bacteria that can cause STIs. There's other viruses that can cause STIs. But these are just some ones that I wanted to highlight. And then an example of a parasite, and I think this was on the Instagram, that can cause an STI is trichomoniasis. Um, so why is it actually important to talk about what causes it and what causes these STDs, like whether if it's of bacterial or viral origin? Um, so it really all comes down to treatment. So bacterial, you're going to be treating them with an antibiotic usually. Viral, I would say viral STIs are somewhat harder to treat just because we don't have a huge arsenal of antivirals like we do with antibiotics. Um, and exactly mechanism of action. So you're not going to give, someone might come into the office and say, "Oh, I have herpes. Let me just take an antibiotic." But because herpes is caused by a virus, it's not going to be able to be treated with an antibacterial agent. Parasites as well. It's all going to come down to treatment at the end of the day. And also different diagnostic technologies. So bacteria you can see on a slide. So if you do a culture of the patients, like when you do a culture of the patient's discharge that they're having, then you do certain like stains or slides, you can see bacteria sometimes and parasites. Viruses, you're going to be able to see the sort of cells that clue you to the virus, but you're never actually going to be able to see the virus on the slide or, have a special stain for it in the micro lab that will actually show you the virus. So let's talk about chlamydia. So chlamydia is caused by a bacteria called Chlamydia trachomatis. Like I said before, at the beginning, it's the most reported bacterial sexually transmitted infection in the US. It's also, I think, just the most reported STI in general. So chlamydia infects different parts of the genital system. So like in our patient, we had the cervicitis, so infection of the cervix, or not infection, inflammation, I would say. Urethritis, so inflammation of the urethra. We don't talk about males, but it's very important. STIs are just as common are just as likely to happen in males and females. In a male, it might present with epididymitis, which is inflammation of the epididymis, which is in the scrotum. So a patient might come in with testicular pain. We'll talk about this later, but they would also come in with, maybe pain with urination and discharge and proctitis. So if a patient is engaging in anal sexual contact, they might have the infection in their rectum. So it might present with like painful defecation, or, lesions on the anus. But essentially you want to think about like it's not, one place, some patient might come in with cervicitis, some patient with chlamydia might come in with urethritis. So it's important to sort of keep in mind that it can cause inflammation in different parts of the genital tract. So chlamydia actually can also cause conjunctivitis and pneumonia. So those are not, I mean, technically they're STIs, right? Because, they're being transmitted sexually, this bacteria. But in neonates, they can present with conjunctivitis, gonorrhea as well as there's like chlamydial pneumonia, much more rare. And it's different like strains of the bacteria that cause that. But always like, good to know. And, when in medical school and you're getting like a much more thorough lecture on STIs and the bacteria and everything the bacteria can do. Just, remember that it's not only the genital tract that these bacteria can infect, but other parts of the body as well. So in chlamydia, it would be like the eyes. There's certain strains of chlamydia that can cause blindness. There's chlamydial pneumonia as well. So the symptoms. So again, the symptoms are going to depend on where the inflammation is. So with our patient, she had cervicitis, so that's why she was feeling the pain with insertion. And she had urethritis, which is why she was feeling the pain with urination. In a male patient, they might come in with testicular pain or rectal pain and bleeding. Some other general symptoms that might cause would be penile discharge and painful or swollen lymph nodes. So there's like a different skip too far ahead. So there's in the literature, there's different consensuses about like the discharge. Some people say that like chlamydia has a malodorous discharge and gonorrhea doesn't. And chlamydia will be more of a white or clear or yellow discharge, and gonorrhea would be, more white. But at the end of the day, you're not really going to be making your diagnosis based on how the discharge looks. When you see a patient with any of these symptoms, you want to keep both of these diagnoses, chlamydia and gonorrhea, in mind. In a test question, it might help you, but I don't really think they would, make you rely on the patient's discharge to diagnose the STI. Okay, so gonorrhea, also caused by a bacteria. Here I've actually shown you the bacteria. This is Neisseria gonorrhea. It's a gram-negative infection, which is why it's pink. And if you notice the symptoms, so they're actually very similar, right? Discharge, pain with urination, pelvic pain, testicular pain. That's why gonorrhea and chlamydia are really hard to distinguish. So again, I don't really think you're never going to be making a distinction just based on the clinical picture. You're always going to want to get testing. People say that the discharge is more white, green, or yellow, and it's supposed to clear in chlamydia, but again, you're not really going to be making a diagnosis purely on the color of discharge. Something called a disseminated gonococcal infection. We'll talk more about complications later on. That's when a patient can have joint pain and rash as a result of gonorrhea. So they might or might not present with these genital symptoms as well. But you might have like a 19-year-old woman coming in with like 2 months of joint pain. And it's not because of, it ends up being because of gonorrhea. Oops. All right. So like I said, they're really hard to distinguish from each other. And they often appear together. So patients will often have co-infections of gonorrhea and chlamydia. So you might not always be actually differentiating between the two, and we'll talk about how that comes into play in treatment soon. And this is what I really want to drive home, and probably should have mentioned it earlier, but many patients, as high as 77% are asymptomatic. So I had a patient in my family medicine clinic come in. She, said she was sexually active, but she was feeling totally fine, and it turned out that she had chlamydia. So we'll talk about screening later, but that's why it's so important to get a sexual history, even if a patient isn't presenting with any symptoms. Obviously, you want to only get it when it's appropriate. So when they're coming in for the annual physical, obviously not if they're coming in for if they're coming in for like a headache, you don't need to ask them, what kind of sex they're having. But it's really important to get a thorough history. Let me just look at the chat quickly. Yeah, so there's a whole in terms of the chlamydia causing pneumonia and conjunctivitis, so it's often caused by, let's say, a woman having chlamydia and then transmitting it to her fetus. That's a lot of word like that's where the neonatal conjunctivitis, that's where it would come from. And yeah, so many long names. Microbiome, I was just memorizing all these long names, but I loved micro. I thought it was really interesting. So yeah, screening is so important because a lot of these infections are asymptomatic. And if you remember our patient, like these symptoms weren't really bothering her that much. She thought she just had a UTI, and so she's like, okay, I'll take some cranberry juice. But yeah, it's really important to screen. Right, let's keep going. All right, so why do we want to treat it? It's really important to treat gonorrhea or chlamydia because they can have all these different sequelae. So first of all, it can cause pelvic inflammatory disease, infertility, ectopic pregnancy, and Fitzhugh-Curtis. So I'll talk about that next slide. So pelvic inflammatory disease is essentially when you have like diffuse inflammation of the uterus, ovaries, and fallopian tubes. So I've included this photo here of this is a uterus, and you can see on the side are the ovaries and the fallopian tubes, and they're exquisitely inflamed. And that can be due to a gonorrhea or chlamydia infection that was untreated and was able to sort of ascend through I guess maybe the vagina or the cervix and really cause this diffuse inflammation. Fitzhugh-Curtis syndrome is actually the infection can travel to the liver and cause inflammation of the liver capsules. So the patient might present with like right upper quadrant abdominal pain. And you can see here, this is the liver and this is the peritoneal wall. And then ectopic pregnancy. So essentially what can happen is in pelvic inflammatory disease, because you have this inflammation, what happens with inflammation is you get scarring. So think about pregnancy, right? Think about the egg. It travels, laser. It travels from the ovary, and it ideally, wants to come all the way to the uterus so that if the egg is fertilized, it can implant properly in the uterine wall. Let's say you have all these adhesions, all this like scar tissue from having a pelvic inflammatory from having a history of PID or pelvic inflammatory disease. Let's say like um, this part of the fallopian tube is all like scarred up. Um, so A, it might cause infertility, right? Because the egg might not even be able to get um, to the uterus to be fertilized. But it also can cause an ectopic pregnancy because let's say you have like adhesions in the uterus, like all the scar tissue here, then the closest place for the embryo to implant might be in the tube, or even lower down on the cervix. So these are really serious complications. For those of you who don't know, I should say ectopic pregnancy is when the embryo implants somewhere that isn't the uterus. And in really serious cases, it can cause like, intraperitoneal, intra-abdominal bleeding and death. So it's really, really serious. And infertility as well. A lot of the patients who come in are with STIs are younger patients who might want to have children in the future. So preventing infertility is something really important. So that's why we treat STIs. It's why you don't kind of just say, all right, go home, it'll resolve itself. So diagnosis, so we kind of talked about it before, and oops, it's I think a little bit out of scope to talk about the different tests that you can do for STIs and um, for gonorrhea and chlamydia specifically. But the way to make a definitive diagnosis is through it's called the nucleic acid amplification test, which is when you just kind of take the swab, put it in the tube, and send it off to the lab. You don't have to worry about it anymore. We don't really have to worry about how it works. I think that's not really something you're tested on in medical school. But you can collect the samples anywhere in the cervix, the vagina, the throat, or the anus, wherever the bacteria actually is. In our patient, again, it was the cervix. You can also do a urine sample, which is you can just sort of test for the STI from the urine. And you don't need to do a culture. So a culture is essentially when you take a sample from the urine or the cervix, and you culture it. You put it on your dish with all your media, and you like incubate it and let it grow, which takes a few days. So that you want to do. The reason that we do that in medicine is because we want to see what bacteria it is, because different bacteria are treated with different antibiotics. But for certain things, you don't need a culture to see what bacteria it is. That's how we have these like nucleic acid amplification tests. Um, so sometimes they'll culture. I don't think you would really culture like fluid in an STI case most of the time, but it's not definitely not required. So I would say this is more important than this thing is screening. So screening is essentially like the how you're doing the testing, right? Like how, when, who. So obviously when a patient comes in with symptoms, you want to test. What about these asymptomatic patients, right? Like, let's say this patient had come in and she was totally fine, and we're like, okay, great, you don't need any tests, we can send you home. But the USPSTF, which is the U.S. Preventive Services Task Force, recommends screening for gonorrhea and chlamydia in all sexually active women 24 years or younger and older if they have increased risk for infection. So essentially, any patient who's under 25 who comes in and tells you they're sexually active, you want to screen them or test them for gonorrhea and chlamydia. However, this is interesting. They do not necessarily have the same amount of evidence to recommend screening for chlamydia and gonorrhea in men. So obviously, this is going to be a decision of the provider, who they're going to test, if they're going to test just women or men as well, patients who don't have symptoms. But I would say the major takeaway of this is that even if a patient is asymptomatic, they can have gonorrhea or chlamydia. And so that's why we want to test anyone who's in this age bracket who's sexually active. All right, so I touched on this early, but maybe you're thinking, okay, well, there's such good sex education now, and I'm sure all these patients know that they're supposed to use condoms to prevent STIs. But if you look at the data from the CDC, since 2014, STIs are on the rise. I think the most recent data shows that there's actually a slight increase after 2019. But overall, STIs are increasing. We're not really sure why that's happening. If it's poor education, like poor adherence. But it's kind of an issue, right? Like I said, it can cause all these complications. So we really want to make sure that we're being diligent about screening and testing these patients and then treating them. Quick note on treatment. Like I said, antibiotics. For chlamydia, you're going to treat with doxycycline and azithromycin. Gonorrhea, you're going to treat with ceftriaxone. Here's the key takeaway. Let's say a patient comes in, they have symptoms, you're not sure which it is. You send the test. Test is not going to come back for 2 days. You treat both. You give them doxy and ceftriaxone, or ceftriaxone and azithromycin. But until you actually have definitive results, of what STI it is, you want to treat both because you want to, make sure that you're not missing something. So let's see the chat. Some theories about why the STIs are increasing. Could be a data. Yeah, it could be a data issue. I wasn't aware of that. I didn't see anything like that in the literature, but that definitely could be poor access, maybe to like contraception or condoms, maybe. Yeah, there's a lot of research on this. I'm not exactly sure what the primary cause is. So this is interesting. Before we end, counseling and prevention. So like I said, we want to make sure that this doesn't happen again. Gonorrhea and chlamydia can recur as often as 20%. So we want to talk to our patient, find out why she's not using condoms. Maybe she doesn't know that she needs to use condoms every time, or like there's a certain barrier in place that we can help her address. But now it comes to her partners, right? So that can be a really uncomfortable conversation to have with someone. And a story that this actually happened more than once to me when I was a medical student or this past year. A patient will come in and they'll be like, I've been monogamous with my husband for the last 5 years. And then they test positive for chlamydia. And then, it becomes an issue of like, oh, maybe they got it from their husband who was, being sexually active with someone else. And then you kind of you're in this weird position where, they find out maybe that their husband has been cheating on them because of this STI, and it's a really awkward position to be in. But anyway, tangent. You want to make sure that the patient's partners are treated as well. So there's something called expedited partner treatment, which is basically, let's say this patient comes in and she has chlamydia. I'm going to give her dose of doxycycline. And if you live in a state where you can do EPT, you can actually give her a dose of doxycycline to give to her partner so that they don't have to come in. There's also something called tellyourpartner.org, which is you can just go to this website, put in anyone's phone number, and they'll anonymously text them and say, someone you were sexually active with in the last X amount of months tested positive. We recommend that you go and get tested. So, that can be like an easy way for the patient to let their partners know without feeling embarrassed or awkward, because it's really important to make sure that the partner is treated as well. Okay, 2 questions in the chat. One is multiple antibiotics. Would you give a probiotic? I'm not sure. That's going to be a very provider-specific decision. It would be based on the evidence. Like, is there evidence that patients have, adverse effects of these antibiotics that probiotics help? False positives are always possible, but it's not like these treatments are super dangerous. So I would say, like, it's better to treat someone who doesn't have an infection than not treat someone who does have an infection. So yeah, like with any test, there are false positives. I don't have the specificity or the sensitivity of the tests, but always possible. All right, so that's it from my slides. Questions. Let's see if anyone has anything in the chat. Probiotics are recommended, but not always. Again, it's going to be not partner. It's going to be provider dependent. I've never seen a provider diagnose probiotics, but could have just been people I was working with, so it depends. If anyone else has any questions about anything in the presentation, or anything else, anything about med school or pre-med, feel free to drop it in the chat or log off. It's already 9:30. Any vaccines for some of the infections? Oh, I forgot to mention this. Yeah, it's a question on the quiz. So the only STI that's preventable by vaccine is HPV. HPV there's a vaccine that's given to, I think, 9-year-olds in either 2 or 3 doses, and it prevents against HPV, which also in women prevents against cervical cancer. It's really a great vaccine. It's pretty new. It's, a great way to prevent cancer. It's like one of the only cancer preventing vaccines too. Um, and it can be given up to the age of 45, or that's what the recommendation is. So for those taking the quiz, HPV is the only sexually transmitted infection that is preventable by vaccine. Yeah, tell your partner is great. Some infections can create antibodies. Yeah, so um, I'm actually not sure about all of them. I don't. You have to double check 'cause I don't know, but I'm not aware of like any specific antibody testing for gonorrhea and chlamydia, but recurrent infections are possible. So I'm going to say that there's like no antibodies. Like these infections are things that you can get a lot. Sorry, more than once. So I don't think there's any antibody. Um, and then this is a different presentation for another time, but something like herpes is going to be recurrent. So once you have it, it never goes away. So you can have like a reactivation. So there's not necessarily an antibody for that.
Well, there, Kira, thank you very much for the presentation. It was amazing.
Great, thank you.
Thank you.
Of course. So, can you tell me what is your day in life like as a third year medical student and going up to fourth year? And I see you're moving on very well. Proud of you.
Yeah, so third year you're gonna be in, I mean, some schools are moving to an earlier curriculum now. Um, but third year you're generally gonna be in the hospital. So, you start your day depending on what rotation it is. So for example, surgery might start really early at 6 a.m., but family medicine might start later at 9 a.m., depending on what time your team starts. You get to the hospital, you participate in whatever they're doing, so rounds, or if you're an outpatient, you might just be seeing patients in clinic. You're essentially sort of a part of the team while you're in the hospital, um, seeing patients, presenting, that kind of thing. If you're in surgery or OBGYN, like participating in procedures, scrubbing into surgeries. Um, and then your day can end again. It really depends on the hospital you're in, rotation you're in. Um, Surgery, I wasn't leaving the hospital till 6 p.m., but like psychiatry, I left at like 3, 4 sometimes. And then when you get home, unfortunately, you have to study because you have something called shelf exams, which are exams you take at the end of every rotation. So at the end of your surgery rotation, you take a surgery exam. At the end of your psych rotation, you take a psych exam. So essentially, third year is basically you're going to the hospital, uh, you're participating in patient care, and then you're going home and studying. Someone asked what specialty. I'm interested in psychiatry right now. Someone asked what forms of assessments have we been primarily graded on. So first year it's exams. In my school we have exams every 4 to 6 weeks your first 2 years. You also have like small group classes that you might be graded on your presentations or your participation. And then second year, at least in my school, and a lot of schools have this similar system where you're graded on sort of your final grade for each course comes as a combination of your clinical performance. That's based on your evaluations from your attendings and residents, and then your shelf exam score. So at my school, they combine the two and give you a final grade. Every school has a different way of, um, you know, getting you a final grade based on how you did. A lot of schools are, pass fail. My school's pass fail the first 2 years. And then this third year, it's honors, high pass, or fail. But third year, it's mostly just clinical evaluations and exams. We don't have any quizzes. Or we have a couple of assignments, but it's mostly exams and clinical assessments.